total arch revascularization, I mean a patient who's had both his carotids and both his subclavians recanalized or opened up. And we've done 14 such cases, and I'll just show you a selective few. This is a 21-year-old lady who came with arm claudication, multiple strokes, aphasia. This is the baseline angiogram. You can see basically everything is gone. She was living on the right vertebral artery and the left vertebral artery. The right vertebral artery comes off after an innominate stenosis. So this is a pretty bad situation. And she's already had multiple strokes. And we did selective angiograms into each of these vessels. There was thrombus in the right carotid system. And the other two arteries were occluded. So the first vessel we opened was the left carotid. And we got a good result on the right, you can see. And this was just a plain balloon dilatation. So we did not stent this. Then we opened the left subclavian artery. But here we stented. This is a 20 centimeter long stent going all the way to the brachial artery. And this was a week later, we did some more work. The carotid and the subclavian were working well. And we found that the thrombus had cleared from the right common carotid. And we opened the right subclavian at this point of time. And we also opened the right innominate and did a balloon angioplasty of the right carotid. So finally, we got everything open. And this was just a couple of weeks back. And we're getting her on follow-up. This is another case, a 41-year-old male who's a percussionist who plays the tabla, came with arm claudication and giddiness. This is his arch angiogram. He's got these very, if you look at the two carotid arteries, they're terribly diseased. I'll show you better pictures now. And both the subclavians are occluded. So this is the left carotid. If you take an angiogram, you see this kind of mesh of channels within the diseased segment of the artery, and it's like going through a maze, getting a wire through this, and we ballooned it with a 3 and a 6, and finally stented and got that result on the right. And you can see that area of the aorta is slightly bigger than normal. Then we opened the left subclavian artery. You can see it's a long occlusion going all the way to the brachial artery, stented it with a long stent. You can see the stent in the left carotid also there. And now we have a 6-month follow-up angiogram showing patent left subclavian artery. The arterial pressure here is as the same as in the lower limb. And then that's the left carotid stent still doing well 6 months down the line. So this time we opened the right subclavian, again with a long stent, and we opened the right carotid. And you can see that same kind of lesion. I don't know if it's been described, these kind of multiple channels through the disease segment of the artery. It was like running through a maze. We've got to get a wire through this, balloon it, and stent it. So as you balloon it, that maze collapses. And finally, you get this post-stent result, which looks like there never was a maze there in the first place. Now, all this, you may ask, what happens in the long term? So I'll show you 3 cases long term. This is a case with very active disease. She had already come with multiple strokes. She's blind in one eye. She has no upper limb pulses. She's having seizures. This is a CT scan, multiple strokes already, 3 strokes at least here. This is the arch angiogram. Practically everything's gone. The only flowing is the left carotid with one very tight stenosis there. So we got to work on her. Surprisingly, the abdominal aorta was fine. So we opened the right carotid here and the right subclavian. That's in June of 2010. Then we opened the left subclavian. That's in August 2010. And then this is in August 2010. We got these 3 vessels open. And then now we're going to open the 4th one. That's the left carotid. And we opened that one as well in August 2010. Now, 2 months later, she came with yet another stroke. And we really were surprised by this. And we found the stents were all open. And she recovered almost fully. But we still haven't got an answer to why 2 months after opening all these vessels, she had a stroke. Maybe it was an ischemic stroke. Perhaps there's intracranial pathology we missed. Anyhow, the angiogram now, this is now March 2011. You can see restenosis coming in because the disease is still active. And I've marked out those 3 points where we did balloon dilatation of the stents and got them open. And this was the final result in, again, this is the 3rd round in August of 2011 where we did balloon dilatation only of the subclavian arteries. and got this result, August 2011. And this is the left subclavian which we ballooned. And now we've come to March of 2012. You can see the carotid stents are doing well. They're open, but the subclavian stents are still restenosing. Activity is still going on, ESR34 and CRP56. She's on immunosuppressive therapy. Balloon dilated the subclavians, got them open again, and this is the left subclavian. And what we see is finally this restenostic process settles down once we get the disease activity under control. What about if there is no activity? This 23-year-old medical student came with all vessels occluded. We opened up the right common carotid in 1998, and that was the result. You can see the arch has nothing else, just this one opened vessel. And this was we opened the left carotid after that in 2000, and now in 2012, 13 and 14 years later, these two stents are wide open. This patient did not have a disease activity. And we opened the left subclavian this year because he had this bilateral absent upper impulses. Here's another case, 17-year-old girl with syncopal episodes, all arch vessels occluded. We opened the right carotid, stented it in 1998. And in 2009, that's 10.5 years later, the stent is doing very well. She actually lived on this one stent for these 10.5 years, practically asymptomatic. So this time we went and opened the left carotid, the left subclavian, and you can see that there's a kind of a irregular outline of that carotid stent. We find that later on we can smoothen this out with balloons, or spontaneously it may smoothen out. But finally we do get good long-term results. So the important things are you need to persist and repeatedly dilate if the lesions are restenosing, but we ultimately win. We have not really lost a case where we say, okay, give up, we can't fix this. And the other important thing is you have to be very, very aggressive in medical therapy. We use a range of drugs. We work closely with the rheumatologists, and we seem to have better disease control now than we did have 15 years ago. Thank you.
Thank you, George, for excellent presentation. The fourth case, there is recurrent emboli and multi-infarct. It may not be related to arteritis. Most like some other causes, even after the successful result of the carotid stenting, still has got the infarct. What are the causes may be postulated in this case?
There are two possibilities we think. There may be intracranial pathology which we have not identified, because sometimes we have seen Takayasu with intracranial pathology. Second is the arch was diseased, and some of them do have emboli from diseased aortic arch regions. And so we actually put her on long-term oral anticoagulation in that case. But we still haven't got an explanation why 2 months after opening the carotids and getting a good result, she should have an ischemic stroke. And the stents are widely patent. We did another angiogram. So I don't have an explanation for that, but maybe we missed something intracerebrally in that.
LV function is good, no, in this patient?
Yeah.
Because some cases arteritis, the LV dysfunction may clot, maybe there, it is good.
Thank you, Professor Joseph.